So early CABG failures. So we feel that CAD is a like highly inflammatory disease. It's a different animal in India, and early CABG failures have been historically linked to anastomotic site stenosis and the surgical technique. However, it may be related to the progression of atherosclerosis because of pre-existing risk factors. It may be influenced by the operator experience, by the type of surgery that is off or on pump, and the conduits that are used. There is also a need to continuously analyze other risk factors that may influence the early failure of CBG, especially the inflammation. So the study was actually designed to know if there was something that we were missing other than the technical failure, that is technical aspects of CBG being like leading to its failure. So we try to analyze the demographics, patient and the operative characteristics and the clinical features of patients undergoing early reinterventions, which we defined in our study arbitrarily as within 2 years for this study. There is one study by Magnus Dahlen from Sweden, which he says they call it primary CABG with a different like connotation, which means no past PCI was done and no past CABG was done. So that was done as the first surgery, first intervention. I mean, we have used both LR and ML for this, and we have determined the determinant cohort and then studied it in a validation cohort. So this is the study that we have, sir. We have 1367 patients who underwent CABG as the first intervention. This was done from 2001 to 2015. All were done by 3 operators with an experience of more than 100 procedures per year with expertise in both off-pump and on-pump CABG. The patients who underwent any past revascularization, that is PCI or CBG, were excluded to actually reduce the confounders. And we had a validation set which we started on Jan 1, 2016, went ahead, which is actually just 28 patients, but it's actually evolving. So we had this kind of a data that is 11.7% in the very end, sir. I mentioned that 160 patients underwent a reintervention within 2 years of the index CABG. In the overall cohort of these patients, the age mean was 57 with more dominance of males, with 65% being diabetic, with also having dyslipidemia, that is HDL less than 30% was seen. It's a mistake of 75, it's actually 25, sir, I'm sorry. Was seen in about 25% of people, and HDL, LDL less than 150 was seen in 46% of people. There was a significant family history also, and we had patients who had a prior MI also. Again, in the entire subset, we got about 89.5% of patients having off-pump surgery. We got a HbA1c of 8.9 mean. We got an LVF of around 47%. Excuse me. We had an HDL of around 37, and the other factors have been actually mentioned here. Serum creat of 0.8.9. Excuse me, sir. Serum albumin of 3.2, CRP of more than 5 in 56% of people. So a lot of them were in the inflammatory kind of range, N by L of more than 5 in about 44% of people. The average ventilation time was 16 hours. Of these, as I said, around 11.7% underwent like a repeat CABG, of which of these, 160 have come back, of which 134 underwent a reintervention, of which 125 underwent a PCI, 9 underwent a repeat CABG, and 26 patients were managed medically. In terms of anatomy, new lesions of the on the CAG were seen in 25% of patients with approximal lead involvement in 75%. SVG graft loss was seen most commonly in about 75% of people. That was the anatomical thing. So we did a baseline analysis in terms of univariates. That is, we have seen dyslipidemia much more common in these patients. We have seen there is higher like admission sugars more than 300, HbA1c more than 8.5, and active smokers. We have seen a residual syntax score of more than 8, which is significantly higher. Like more of them remained unvascularized because of poor vasculature, poor runoff. We have seen that we had used bilateral IMA, LIMA, or a free RIMA in almost quite higher number of patients. That is, SVG grafts were more likely to be lost. Also, in terms of CRP, albumin less than 3, we have taken albumin less than 3 as an inflammatory marker, significantly higher in these.
What is the numerator there? Early intervention is how much? No early intervention is how much? Is it 160 versus the remaining, or
134?
You
sir.
need to put the numerator.
Sorry,
you
sorry,
said 160 initially. Now it's 134 versus how much?
So 134 of them totally underwent an intervention.
So you are comparing 134 versus 26, or 134 versus 1369 minus 134?
So the total figure.
Okay.
Total. So MPV is a mean platelet volume of more than 12 femtoliters. More than 10 is considered as a risk factor. FL, sir. Femtoliter, sir. Total platelet count, sir. More than 4.5. 4.5 was seen in 8% and less than 4.3. 4.5, sir. Can I go ahead, sir? In the regression analysis, we found out that there was much more renal dysfunction and a serum creat of actually more than 1.5 in those who had early reintervention versus those who had no early reintervention. Atrial fibrillation was significantly higher. Uncontrolled DM was seen significantly higher in those patients past anterior wall MI. If the number of grafts was more than 4, I'd like to include here that if there was an SVG graft also, and HDL less than 30 was significantly higher. On the regression derived score, we got these as the actual predictors, with a total score of 18. We have also seen in terms of the precision recall curve, it's around 0.671. This is actually used in unbalanced data sets because we are comparing a smaller number with a larger number. With AUROC, again here, sir, it's around 0.68. This is taken from my laptop. We have applied ML to this. I'll skip this slides because I mentioned this in my earlier talk. This is again trying to get a heat map of each of the predictors versus each of the predictors. And when we saw all of them in terms of the ones which are redder or more orange are the ones which are more likely to have a higher like a predictive value. So when we went in terms of that, it's a little small to see, sir, but when we actually got that the highest risk factor was about the sugars that are more than 300. If the patient's age was less than 50, he was more likely to lose the graft, probably because of an inflammatory state, rather than age more than 50. If there was an SVG graft, use RCA graft, diagonal graft, or if you had an additional diagonal graft versus a TAR. So all that were more likely to be lost. Off-pump CBG did significantly worse compared to on-pump CBG. Failure of DAPT to continue, failure of statins to continue also, I have actually put it down. And then CABG following a recent ACS, if the syntax score was more than 27, or as I said, the residual syntax score was more than 8. That is also a predictor. The need of increased mechanical support following CABG immediately, emergency CABG, delayed sternal closure, if the patient could not tolerate statins, or if there was a post-op renal insufficiency. All of these were given their hazard ratios, and then an ML analysis. The score was around 35, sir. We actually went in terms of tertiles again, 14 to 25, and more than 26. We saw that we had a very good probability of reaching primary endpoint if it was more than 26. We have actually only a smaller validation cohort, sir. We don't have too much of it, but then whatever we got, I agree it's a small thing, but we still got a better AURC on it. The insights are just that, sir. There's uncontrolled sugars. We feel that it's not just technical factor. It's also that there is a lot of inflammation in these patients. Though the bilateral IMA does well, that is something that we we know already. Inflammatory markers and their weightage has not been greatly mentioned in literature, or they have not been studied as a composite model, especially the serum albumin less than 3, A by G ratio, higher N by L, higher CRP. They have not been studied compositely, though in like multiple shorter studies they have been told. And of course, inability to tolerate statins was significantly higher. So probably if we are able to do that, they will be likely to be controlled in terms of anti-inflammatory drugs. Thank you, sir.